Kat, that's really happening. Mark is coming in as you, I think.
Look.
This is oh my God, is this your worst nightmare? Everybody is you. Oh, now it corrected. No, it didn't. Kadu, your cat.
Well, that's very strange. Well, I guess it's probably just Hi everyone. I'm glad we're all having the same name today. This is bizarre.
Is that Mark?
Okay, Mark, can you hear us and see us? Hold on a second.
What? Buli omu azze nga gundi genda gulabe erinnya kiyohiyo so you have to read oliyo nga katumula era nange eryange nzikyusiza bukyusa buli omu abaddeyo buli omu.
Okay, so this was Mark. He just said he can't unmute or turn on his video for some reason. Stella, can you hear and can you see us?
Valentine's here as Kat.
Yes, I can hear you, Kat.
Perfect. Stella,
and I can see you as well.
Perfect. Do you mind turning on your camera?
No, I don't.
Oh, good to see you.
Good to see you too.
Okay, so for some reason, Mark is just rejoining. He had issues. He couldn't unmute or turn on his camera. And I don't understand why everyone's called Cat now. So for some reason, there must be something in the Zoom settings, but I guess we know who we are. Let's give it another minute. I'm going to ask Mark to rejoin. Stella is, oh, there we go. There's JB. Do you know if Dr. Eleanor is coming as well? Stella, JB?
Now let me check on her.
Sure.
Tell Mark he might have multiple Zoom sessions open, because I know if you have accidentally have another Zoom session open in the background, it won't let you turn on your video. I think
okay.
Yeah.
Okay.
Hi, Ed.
Hi, everyone. Thank you for joining.
Hey, Ed.
Hello.
Yes.
Okay, here we go. Mark, you're back. Can you hear us now?
Yes, I just switched to another device. I don't know why that's happening, but it's fine. Thank you.
Yeah, something's weird. Also, we all share the same name. But anyway, right, we're 2 minutes in. Maybe we could just get started as more and more people will join. Thank you so much for joining. We got some of the BAMA USA Board members here. We got some of our amazing staff members in Uganda. And as you know, this part is really just an opportunity to get to know our staff better, to hear firsthand about the work that's being done right now, how they're expanding to the West, asking all the questions and really showing some appreciation and understanding better what you do. So I'm Katarina, for those who don't know me. I joined BAMA in 2022, I want to say. And probably what we just really want to do now, we just keep it fairly short and just give as much time as possible for potential questions. With this being said, Julia is our chair and Mark is our ED as well. If there's anything in between you want to interrupt, please do. Otherwise, I would love to hand it over to JB and Stella in Uganda. JB, Stella, do you want to start by introducing yourselves?
Thank you, Katarina. I think Stella will begin.
Thank you very much. I'm JP. My name is Stella. Nalgo Amronje. I am the Mama Rescue Project Coordinator. JB, over to you.
Thank you. My name is Ruka John Bosco, and I'm the Community Liaison Officer at BAMA Foundation. Started working with the BAMA Foundation as staff on contract since 2021. But I worked with BAMA before as a volunteer. Thank you very much.
Beautiful, thank you. Since everyone's sharing the same name, I can't tell if someone else from the local team is here. There we go, Dr. Eleanor.
Yeah, I'm trying to see if I can see myself, but I hope you can see me. My name is Elena, and hi everyone. I'm the program director for Babies and Mothers Alive, and good to see you all once again.
And then we also got Dr. Dan. Dan, do you just want to quickly introduce yourself as well? Dan, if you can hear us, this is the Mula with Dan's picture. If you could hear us, just say a quick hello, that'd be great. Otherwise, we just move on for now. All right, let's come back to this later in a bit. I guess what would be wonderful just to get started is if you start telling us a bit more about what's happening in Uganda right now, where you are, how we're scrolling to the west, and just giving a bit of a context for everyone here to understand more of like what you do on a daily basis and how we're currently expanding to the west. JB, you want to start, Stella or Eleanor?
Stella will begin.
Yeah. Okay, Stella, go on, please.
Dr. Elena should begin, I think.
Hey, it's okay. I'll put my video off to increase the bandwidth. Is that fine?
Yes, please. And Stella, no, you please. You're the lead person, so please you proceed.
Okay, thank you so much, Dr. Mark. I request to remove my camera. I hope that's okay. So Mama Rescue, we implemented Mama Rescue transportation that saves lives in Rakai and Chotera for more than 2 years, and we're able to transport over 27,000 mothers from home to health centers to give birth with skilled midwives. We're also able to transport mothers, over 3,000 mothers, from lower facilities to higher facilities for urgent obstetric care. And given the success of Mama Rescue in Rakai and Chotera, we're able to secure funding from Enable Uganda to implement Mama Rescue project, life-saving transport and savings for health in Kasese and Kabarole districts. The main aim of Mama Rescue in Kasese and Kabarole is to improve the living conditions of the most vulnerable population by increasing access to health services for expectant mothers and workers in the informal sector. We have 5 specific objectives, with one of them being increasing access to quality health services for expectant mothers and informal workers. We are also hoping to improve community awareness and utilization, increasing access to quality maternal and newborn health services through transportation. And here we hope to transport 25,000 women in labor from home to health center to give birth with skilled midwives. We also hope to refer 2,500 mothers experiencing life-threatening complications from lower facilities to higher facilities for urgent obstetric care. We also hope to improve community awareness and savings for health amongst 6,000 women and informal workers in the 200 VSLS, Village Savings and Loan Associations, And we also hope to improve quality of antenatal and intrapartum care. We have 7 result areas. The first results is increasing awareness of 40,000 expectant mothers. So we hope to sensitize these mothers to attend antenatal. Also ensure that these mothers are recorded. We hope to transport 25,000 expectant mothers from home to health centers. That is our second result area. Our third result area is referring 2,500 women with life-threatening complications from lower facilities to higher facilities for urgent obstetric care, as well as ensuring that we sensitize 6,000 members, village savings and loan association members, to start saving for health in 200 village savings and loan associations. We also hope to establish one pilot expectant mothers waiting home in one of the districts, as well as documenting lessons learned and best practices. So far, we have achieved, we have completed district entry meetings, inception meetings, and we also conducted the baseline survey. Right now, we are writing the baseline survey report, and we hope to conduct mass media programming and do the trainings. So I would like to call upon JB to take us through the community component more, to talk more about the community component this side. JB, over to you. Thank you very much.
Thank you, Stella, and the panel for listening. Mine is very simple. It's about the community. Like Stella was mentioning, of a lot of resort areas, we don't do them physically as BAMA staff. We work with the community, and therefore.
But still verify me if you could.
And therefore, our role is to solicit support, to work with the human resource and so on. And therefore, like when Stella said, we are going to transport 25,000 mothers. Yes, it is true. We are going to transport 25,000 mothers from community to facility to give birth, and we use motorcyclists. So as the community component, we have already mapped the riders to work with. We mapped 256 riders, but of whom we are in the process of vetting them, because we only need 120 to work with, to train on safety measures and so on. So we have already mapped 2,500. We are now in the process of vetting them using other stakeholders, community stakeholders, like the facility in charges, like the sub-county chiefs, the local council leaders, and so on, so that we are certain of the people that we are going to work with, their discipline, history, their law-abiding capacities, and so on. So we already mapped them, and we are now in the process of vetting them to get or to select only 120 of them that will help BAMA transport these expectant mothers at the time of birth and take them to facilities, but also to vet 50 drivers of motor vehicles or cars, the small cars, saloon cars, that will be helping us in transporting mothers with complications from a lower health facility to a higher health facility. Also, the process of vetting them, finding out whether they have what it takes to drive cars. Are their cars in the good shape? this is the process we are in, and we do it together with other community stakeholders. Like I'll mention, we also have established relationships with the area cultural leaders and religious leaders. Like I said at the beginning, we are not physically doing this work ourselves without the communities. Now, these religious and cultural leaders become BAMA's pieces in their communities where they are. We know they have they have followers. Religious leaders have Sunday services, Friday prayers, and so on. So it is them that help us to convey the messages of BAMA, especially to do with maternal and child health services, to their people. Now, in so doing, they become BAMA's ambassadors. And it is important for us to work with them because it will take their trust. The people take their trust because we are working with them. And in so doing, they also end up trusting BAMA. She also said, Stella also mentioned about sensitizing 40,000 mothers, 40,000 expectant mothers to attend antenatal care clinics. Yes, and this we do it with, we call them BAMA ambassadors, but in the Ministry of, Uganda Ministry of Health ranks or hierarchy, they are called village health team members. Now, these we have already mapped to them, 100 of them that we're going to work with. What is remaining is training them on how to work with them, what are their roles in communities, especially when it comes to do with sensitization of expectant mothers to attend antenatal care and also go ahead and give birth at health facility level. We have also mapped 301 village and saving loans associations. She mentioned that we are going to work with these groups to save for health. Yes, and the reason we have mapped them is to understand what they are saving for. And we have realized a lot of gaps in them. First and foremost, we appreciate that they exist, but now we are putting our heads together to address the gaps that they have, so that before we even ask them to save for health, for them to understand or even to prioritize the reasons why they save. If they are saving for clothes for Christmas, is this the priority in their lives? Is this what is more important, to wait for Christmas in December? We have a lot of things to do with them, and we are now in the process of organizing and preparing the sessions for them, for these groups that we shall be working with, so that even before we introduce saving for health, it will be a consequence of very many things. For example, financial discipline. For example, financial literacy. What are the goals and what is the vision and goals for saving? Then at the end, we introduce saving for health. Why do I need to save for health? Do I need to prepare myself for being sick? All this comes with a lot of commitment, but not only from BAMA staff, but also from the community stakeholders, like the community development officers, like the parish chiefs, like the ambassadors, like I mentioned, because these are the people that will be mandated with sensitizing, with training, with teaching these groups in their different villages, in their different sub-counties, in their different capacities. I think for now, I can stop here. Thank you very much for listening to me.
Thank you both. That was very inspiring and a great foundation on which we kind of base our questions on. And with this, I would like to open the Q&A. You two, and together with Dr. Dan and Dr. Eleanor, really are the experts here. And this is just an opportunity for us, for external friends and partners of BAMA, for donors, for the board, to get to know your work even better. Pooja was the first one, and she said, as you mentioned, the community aspect is very important to continue to spread awareness and support. And it seems like there's already a big support system. Do you run into any issues with getting members of the community to support or come on board with BAMA? And if so, what are some of the reasons? Who wants to take this question?
Okay, I'll start with it, and maybe some others will supplement. Do we run into issues? I would say yes, sometimes, because when you're introducing yourself to a group of people, they see a potential, how can I say, a potential savior of so many problems, because they have not yet understood what BAMA is. And since BAMA is new in the Rwenzori region, once you come, they want to overload you with a lot of concerns, a lot of their problems. So, but as time goes on, they understand that we are taking the direction of maternal and child health, and they appreciate what we are doing, and therefore their concerns will only be in maternal and child health services. However, there are some issues that we cannot run away from, because they indirectly affect us and our work. For example, let's talk about domestic violence. And this is the reason, for example, BAMA does not address domestic violence, but working together with community development officers, such people that are going through domestic violences are linked to community development officers to be assisted. And this is where our help comes in, linking such a person, linking such women, such children, going through those obscene activities, like being beaten at home, being battered at home, and you link them to respective offices or government offices where they can get help. Yes, we meet some issues, but because we're working hand in hand with other community stakeholders, we are able to link them, we are able to refer them to appropriate offices. I thank you.
Thank you very much. And I would just, love to have this more of an ongoing discussion. So Julia, if you want to continue with the next question already, and if there's something in between, what Stella, you or Dr. Eleanor want to add, please also feel free to have this really over vibrant dialogue. Julia, do you want me to read it out, or you want to ask me to unmute yourself and ask the question directly?
My internet is, so please feel free to start reading if you need to. I was just curious on the, and it's in the chat too, in the regions that we expanded into, are we using the same playbook as we did in our original regions? And does that playbook translate well? Are there, how have we, if at all, had to adapt operations expanded into the regions that we recently did?
Stella or Eleanor, does one of you want to take this question?
Stella or Eleanor, you want to respond? Can you hear?
Yeah, I can hear. I was actually waiting for Stella to come up. But I can respond, and then she can add. So thanks, Julia, for that question. And you want to learn more about our expansion and the activities comparing to the original regions where BAMA started. And now for Mama Rescue, good enough, it was also implemented in the other regions where we were, Rakai and Chotera. Now, transitioning to Kabarole and Kasese, there are a number of differences that come in. One is the language. The language is not the same language spoken the other side, but then the staff who are working on conversant, I would say around 70% conversant with the language being spoken, because working with communities, you must be able to understand the culture so that you know how to approach them. And considering that even the district leadership are also members of that area. So the culture is totally different, but good enough our staff, including the coordinator, have lineages coming from that side. So that is number one. But then number two, you'd go into the ability of the districts to take up the activity. What we had to do in Rakai and Chotera is not different in terms of activities, inception, entry, introducing yourselves, but the ability to take up differs from district to district, and that depends on the leadership. Everything comes from leadership and governance. The demand could be similar, but also remember this Mama Rescue, there's a component of transportation that was also implemented earlier where we are. So we come in with new elements that have not been implemented before, village savings and loans associations, then the ability to integrate ourselves deeply into the community, using the sub-county chiefs, because the previous activities were mainly at the hospital health facility based. But here we come in with a deeper integration into the communities, working hand in hand with the local partners. And then another difference is again in the how do I call it, the structure of the economy. For example, for the taxi drivers, we hope to use referral from the health center 3 to health center 4. It was very easy getting them in Rakai and Chotera, but from the baseline, I think we can just count. We are still in discussions how, because these areas are hilly. Some places you cannot go with a motorcycle. So meaning you have to transport women because they are staying there and you don't want them to die. So that region is hilly. You cannot use the car because the cars are not even there. So we are saying we are going to use the taxis, but in the baseline, they were just being counted. People cannot use their taxis. A border cannot go there. So you have to stop, park your car, walk. So mothers are transported using, I don't know the English word for that, but they are stretchers carried by men with a bed sheet, or they wrap the woman in a bed sheet. And we did not have that in Rakai and Chotera. So those are some of the differences in the approach. And so it's going to change. We are still talking with our donors that we cannot do exactly what we were doing the other side, talking about the capacity of the health facility to handle an emergency when it arrives. So Rakai and Chotera, we had started already with dealing with delay number 3. Health workers were trained. The attitude was different. The health facilities had buffer stocks. Through BAMA, they were equipped. They knew what to do. So here we are. The health facilities probably have received one training. So even during the baseline, this came out clearly. They still do not know much, like where we are coming from. And those are places that we have to start from. Some facilities are overwhelmed. The facility that you have that may handle referrals, life-saving referrals, is overwhelmed. They even treat patients from under the trees. And this is a facility we are saying we are going to use Mama Rescue and we refer patients there. So it's overwhelmed. So it may not work. So the level of facility is different, district leadership, the terrain is totally different. So those are some of the things we have to go through and make sure we still deliver the project and save lives and build skills of the women and men in the informal sector. Over to you, JB. I hope I've tried to answer you, Julia.
That's very helpful, Lenore. Thank you. I just shot the picture of one of the environments there, one of the pictures you sent me earlier about just of the hills and the mountains. And it was also burlesquely perceived really well. Now, unless there's any other questions right now, I would love to just show one or the two other pictures that you had shared me previously, and you can just tell us a bit more about what's happening so we get an even better understanding of your work. But still, the floor is open for anyone else wanting to ask questions just before. You can otherwise use the chat or unmute yourself.
You know, I just had a very quick question. First of all, this has been very, very helpful. Just the to kind of get a better picture of what's actually happening on the ground. I absolutely love it. But just curious, and I know the expansion is early, but just thinking maybe 5, 10 years down the line, what is the next step, or has that even been contemplated? Like, you know, we expand to 2 other districts now. Is the plan to go to 10, or is there a 5 or 10 year plan down the line?
Perhaps I can jump in here just because somewhat that the answer to that question is really so resource dependent. But one of the things that we're trying to do with this, the savings for health component, as you know, or maybe not everyone on this call knows, the Mama Rescue is an application, a very simple mobile phone application. And what are the major cost drivers to implement this is the transportation. The actual IT component is a fixed cost that no matter how many women you're transporting, more or less stays the same. But the transportation cost is the real cost driver. And so one of the things we're trying to test in this scaling is the savings for health component. Can women themselves and their families save enough money to cover that that relatively minimal cost of about $3 over the course of their pregnancy? If we can prove that that can be done, then yes, there's a possibility for expansion. But the real question is the creating a sustainable model that would allow for this to be continually funded, or at least cost shared to some degree. And then additionally, we would hope eventually that the Ugandan government could help pick up some of these costs. But because this intervention is a little innovative, you know, it's not a traditional ambulance, it has some hurdles to cross for government to actually fund taxi drivers serving in the role of an ambulance, for example. So I hope that, I wish I could tell you that we have a fully baked scaling plan, but we're still in the learning phase of how this can best be integrated into a more expansive model.
No, that was great. Thanks, Mark. Appreciate it. And unfortunately, apologies everyone, but I actually have to jump to another 9 o'clock call. But absolutely loved it.
Thank you, everyone. I think we all need to jump out. 30 minutes just aren't enough. However, if there's any other questions, please feel free to email me, email one of the team members, and we get back to you. I can also, the pictures that I just shared in the chat as well, I can just, send them to you as well with some comments from Stella and JB, maybe to get a bit more of a context of what's actually happening. And yeah, we'd love to continue doing this in the future, just having a bit more of an interaction with the local team who do the actual amazing work. So thank you so much for everyone for joining, and have a beautiful day. Thank you especially to our local team, JP, Stella, Eleanor.
Thank you very much.
Thanks, everyone.
Thank you too.